welcome to A Sound Constitution here on CHLY 101.7 FM, a show where we focus on health topics important to our community. This year's team is made up of 4 fourth-year VIU nursing students, and our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available on our show notes on our Facebook and Instagram pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what's being discussed, please feel free to reach out to us on Facebook at A Sound Constitution, Instagram at CHLY A Sound Constitution, all one word, Twitter at ASC_VIU, or email us at asoundconstitution@gmail.com. We would like to start our show by acknowledging that we are on the unceded territory of the Nanaimo people, with a broadcasting range that overlaps the Kwetson and the Sliammon territories. This acknowledgement is done with gratitude to the Nanaimo people and with the intention to increase awareness about truth and reconciliation processes and efforts on Vancouver Island. Additional information and resources surrounding Nanaimo history, reconciliation, protocol, and land acknowledgement can be found on our Facebook, Instagram, and YouTube pages. I'm your host, Dana, and today we're going to talk about abortion and gender-affirming care. Right now, there is a lot of misinformation and discourse about both these topics because people often use them as political cannon fodder in an effort to score voting points. There are people and organizations that spread disinformation in an effort to distort facts to fit both personal narratives and for financial gain. We could dedicate an entire season going over both topics in depth, but today we just want to give a general overview of information to help our listeners better understand what these two terms mean and how they relate to healthcare. Because at their core, abortion and gender-affirming care are simply healthcare. On today's episode, we are only looking at the facts and statistics of both topics. We utilize resources directly from Stats Canada, from peer-reviewed and credible journal articles, and from important health organizations like the Society of Gynecologists and Obstetricians of Canada. Our goal is to bring some light to these topics from a health perspective and how important it is for Canadians to have access to these services. Of course, as always, all our sources are cited in our show notes, which are posted to our social media and YouTube pages. Today, we're going to hear from Taylor, who's going to talk about the ongoing issues around access to reproductive and sexual health care that many rural and remote living women face in Canada. She'll also talk about discrimination racialized women face when accessing reproductive and sexual health, including Canada's history of forced and coerced sterilization of Indigenous women. Later in the episode, I sit down with Anita Carroll, a registered nurse from Options for Sexual Health here in Nanaimo, to talk about their clinic and the important work they do. We're also going to hear from Haben to discuss the facts about gender-affirming healthcare. But to start our episode, Cam has joined me to give an overview about the health terminology related to abortion, the history of abortion laws in Canada, and some of the current statistics.
Thanks, Dana. I'm going to talk about abortions and abortion laws in Canada. A lot of our listeners have probably heard the term abortion, but may not know the actual definition and types of abortions. According to Merriam-Webster Dictionary, an abortion is the termination of a pregnancy after, accompanied by, resulting in, or closely followed by the death of the embryo or fetus. An abortion may be spontaneous or induced. A spontaneous abortion is classified as a pregnancy loss or death of fetus before 20 weeks gestation, also known as a miscarriage. Spontaneous abortions may be caused due to chromosomal abnormalities, reproductive tract abnormalities, or viruses. Risk factors for spontaneous abortions include advanced maternal age, smoking, drug use, chronic disorders, especially if not treated, and previous history. According to the Government of Canada, approximately 15 to 25% of pregnancies end in spontaneous abortion. In addition to spontaneous abortions, there are induced abortions. Induced abortion is the medical termination of a pregnancy. You may also hear this referred to as an artificial abortion, voluntary termination of pregnancy, and therapeutic abortion. Induced abortions are successfully implemented via medication or surgical procedures. Induced abortion is a safe healthcare intervention when provided by a healthcare professional. According to the World Health Organization, comprehensive abortion care is considered an essential healthcare service and includes the provision of information, abortion management, and post-abortion care. However, there are barriers that may prevent individuals from receiving safe abortions, resulting in dangerous and invasive methods of abortions. This poses a major risk for the physical and mental well-being of the pregnant person. The World Health Organization recognizes that annually, 4.7 to 13.2% of maternal deaths are due to unsafe abortions. UN Women demonstrates the significance of reproductive rights, one of which is that women have the right to decide freely and responsibly on the number and spacing of their children and to have access to information, education, and services. So what is Canada doing to uphold reproductive rights and ensure citizens have access to abortion services? Let's start off by learning more about Canada's history with abortion laws. In 1869, abortion became illegal in Canada, with the threat of life in prison to those assisting in abortions. Then, in 1892, Parliament passed the first criminal code prohibiting both abortion and contraception in Canada. This remained until the 1960s, when medical and legal professionals, along with social justice groups, began to fight against the criminalization of abortion. In 1969, Pierre Trudeau's government decriminalized contraception and passed amendments that allowed for restricted access to abortions. Under the new amendments, abortions were legal if the pregnancy was determined by a therapeutic abortion committee to be a danger to the woman. However, access to abortion was not supported by all provinces and was made difficult to access outside of large cities. The next year, in 1970, the first national feminist protest organized by the Vancouver's Women's Caucus leads the abortion caravan and travels from Vancouver to Ottawa. During this protest, 500 women hold a 2-day demonstration in support of the liberalization of abortion. 30 of these women chain themselves to the Parliament Gallery in the House of Commons. And this is the first time in history that Parliament is closed. Throughout the 1970s, many doctors were criminally charged for providing abortions, including Dr. Henry Morgan Taylor, a physician and abortion rights advocate. In 1982, Canada enacted the Charter of Rights and Freedoms. This meant that any laws that infringe on those rights and freedoms could be deemed as unconstitutional. On January 28, 1988, abortion laws were struck down as unconstitutional as it violates Section 7 of the Charter of Rights and Freedoms by infringing upon a woman's right to security as a person. This allowed for abortion to be treated as a medical procedure and was governed by provincial, territorial, and medical regulations. In 1989, the Supreme Court ruled that a fetus has no legal status in Canada as a person and that a father did not have the right to veto a woman's abortion decision. From 1990 to 1991, the Conservative government attempted to introduce Bill C-43, which would sentence doctors to 2 years in prison for performing abortions on women who were not at risk. However, this bill did not pass after a tie vote in the Senate. In 1995, British Columbia enforced the Access to Abortion Services Act, prohibiting protests outside of abortion clinics and doctors' offices to protect vulnerable populations. From 2006 to 2015, multiple attempts at introducing private members' bills threatens abortion rights. For example, Private Members' Bill C-484, or the Unborn Victims of Crime Act, endangered pregnant women's rights by inventing fetal personhood. However, all 46 of the anti-choice bills have been defeated. In 2017, oral abortion pills became available in Canada to terminate pregnancies. These pills were covered by provinces' health insurance. In 2018, Ontario enacts the Safe Access to Abortions Act, as well as Alberta enacting the Protecting Choice for Women Accessing Healthcare Act. Today, in 2022, abortion is legal in Canada. In British Columbia, medical abortions are available for up to 9 weeks from the last menstrual period. In addition, surgical abortions are available for up to 25 weeks gestation. If you would like a more detailed reading of Canada's abortion history, our show notes can be found on our social media. Now that we know more about abortion and Canada's abortion history, let's review some statistics. All statistics discussed are from the Canadian Institute for Health Information and will be cited on our show notes. In 2020, the number of reported induced abortions throughout Canada was 74,155. In British Columbia, induced abortions were reported to be 11,934 cases. The province with the most reported induced abortions was Quebec, with 21,815 cases. In British Columbia, the age group of people receiving abortions remains fairly even across the ages of 18 to 35, with around 1,700 people per age category. Those younger than 17 received significantly less abortions, with 148 reported in 2020. In addition, the majority of induced abortions in Canada were done before 12 weeks gestation. Although abortion is legal in Canada, increased and continual advocacy for reproductive rights is needed to ensure that access to reproductive health care is available for every Canadian. Thank you for listening to me talk about abortion rights in Canada. I hope you've learned something new.
Thanks, Cam, for sharing that information. It's important that when we talk about abortion, we understand what that term means. I know for myself, prior to nursing, I did not know that a miscarriage was actually a spontaneous abortion, or that the vast majority of abortions happen before 12 weeks and are not surgical in nature, or that despite there being no official abortion limits written in Canadian law, every provider, every clinic, and every province has strict limits to performing an abortion. Just like any other healthcare service, there are procedures and policies in place to ensure the health and wellness of the patient. And that's going to lead us into our next topic, access. Access to health services is extremely difficult in light of growing staff shortages and supply chain issues. And that access is amplified for people who live in rural and remote locations. For people needing sexual and reproductive health care, that lack of access can lead to significant detriments to their health and well-being. I'm now joined by Taylor, who's going to discuss the topic more in depth and talk about the discrimination racialized women face, including forced sterilization of Indigenous women.
Hi, thank you for tuning in. This is Taylor, and today I'm going to be talking about the disparities within Canada related to reproductive health care. I will be including topics such as rural access to reproductive care, BIPOC disparities relating to infertility, and I'm also going to talk about forced and coerced sterilizations in Canada. I'm going to first talk about the barriers that individuals living in rural communities face when accessing healthcare services. When looking at safe abortions, this can be a time-sensitive service which creates additional barriers for those living rurally. According to Action Canada for Sexual Health and Rights, which is a pro-choice charitable organization, in provinces such as Alberta, Saskatchewan, Manitoba, and Ontario, abortion providers are only located in urban areas, which is problematic for 35 to 40% of the population living in rural or remote communities. There is a lot of planning and cost associated with having to travel to access abortion services when living in rural communities, which can be quite time-consuming. Depending on their location, people may need to travel out of province to access abortion beyond a specific gestation. According to Action Canada, in PEI, abortion is only available until 12 weeks gestation, Nova Scotia until 16 weeks, New Brunswick 14 to 16 weeks, and in the Yukon and Nunavut, the gestational limit is 13 weeks. In Canada, close to 95% of abortions are done before 12 weeks gestation. However, people may require a later abortion due to factors such as lack of funds to travel to access services, not knowing they're pregnant, and health issues. Traveling out of province adds additional barriers such as financing or lack of transportation for people living rurally. Furthermore, those needing abortion services beyond 20 weeks gestation due to reasons such as the pregnancy posing a threat to their health or when the fetus is not viable have a very limited selection of services available. According to Action Canada, there are only 3 locations in Canada that provide this service. 1 in BC, 1 in Southern Ontario, and 1 in Quebec. This makes it nearly impossible for people living rurally to access these services. When looking at access to overall health services, 55.4% of women and girls in very remote areas have a regular healthcare provider compared to 87.7% in more accessible areas according to Stat Canada. Among Indigenous women and girls, only 35.1% in very remote areas reported having a regular healthcare provider compared to 87.3% in more urban areas. According to Stat Canada, only 8% of physicians practiced in rural communities in 2015. This is a very low percentage considering the amount of people in Canada who live in rural and remote communities. Furthermore, this lack of access to healthcare services makes it difficult for people to gain the support and education needed to meet their reproductive and sexual health needs. I'm now going to discuss disparities that BIPOC people experience related to infertility and pregnancy. The acronym BIPOC stands for Black, Indigenous, and People of Color. According to the Maven Clinic, infertility affects 1 in 8 couples. However, BIPOC women experience infertility at higher rates than their white counterparts and are often less likely to have adequate access to treatment and wait longer before seeking help. Not only do BIPOC people often have insufficient access to quality healthcare, they may also feel hesitant to seek medical treatment due to systemic discrimination and racial bias in medical treatments that can lead to suboptimal care. The In Plain Sights report from November 2020 that addressed Indigenous-specific racism and discrimination in BC healthcare found that 66.9% of Indigenous BC residents experienced discrimination in the health system compared to 4.7% among other BC residents. According to the Maven Clinic, Black women experience a longer duration of infertility before seeking help compared to white women. On average, the difference is 4.3 years for Black women and 3.3 years for white women. Uterine fibroids, which are growths made up of muscle and connective tissue from the wall of the uterus, are also more common among Black women. Although these are typically non-cancerous, they can cause heavy bleeding, pain, and be a contributing factor to infertility. Fibroids are found in 20% of women of reproductive age, according to the American Society of Reproductive Medicine, but Black women are approximately 3 times more likely to be affected. The cause of fibroids is not well known, but evidence suggests that they may be due to a combination of genetic, hormonal, and environmental factors. According to the Maven Clinic, white women are more likely to be offered fertility-sparing surgeries or therapies for fibroids, whereas Black women are twice as likely to undergo a hysterectomy, which is the surgical removal of the uterus, preventing them from becoming pregnant. Furthermore, the BIPOC Women's Health Organization states that Black women are 2 times as likely to experience severe maternal morbidities than their white counterparts. There is also differences between the infant mortality rate among BIPOC people. The infant mortality rate is twice as high among Black women compared to white women according to the Ontario Human Rights Commission. The infant mortality rate is also higher among Indigenous people in Canada. According to the In Plain Sights report, the infant mortality rate among Indigenous people is 5.8 out of 1,000 live births, compared to 3.4 out of 1,000 live births reported in other British Columbia residents. Before I finish, I'm going to address the topic of forced sterilizations. So forced sterilization has been occurring in Canada since at least the 1930s. Many provinces in Canada, including BC and Alberta, had laws in place that allowed forced sterilization on many marginalized groups, including Indigenous women. Although these laws were abolished in the early 1970s, according to the Native Women's Association of Canada, there has been reports of forced and coerced sterilization in Canadian hospitals as recently as 2019. Forced sterilization occurs when a permanent surgical procedure called a tubal ligation, which involves cutting, tying, or blocking the fallopian tubes so that pregnancy is no longer possible, is done without a person's knowledge or consent. A coerced sterilization occurs when a person gives consent for the procedure, but this consent may not be informed. For example, when given the wrong information about the procedure, or they may have experienced intimidation by healthcare providers or offered incentives to have the procedure done. According to the Native Women's Association of Canada, there are reports of Indigenous women being told that the procedure was reversible and they would still be able to have children in the future. According to the College of Family Physicians of Canada, in the years leading up to when the law allowing this ended, between 1966 to 1976, it is estimated that across Canada there were 1,200 forced or coerced sterilizations performed. Of these, 1,150 were performed on Indigenous women. In more recent years, there has been evidence that the practice of coerced and forced sterilization of Indigenous women continues to occur in Canada. The organization Amnesty International discussed a report that was released by the Saskatoon Regional Health Authority in 2017 that documented the experiences of 16 women who reported being coerced into having a tubal ligation between 2005 and 2010. Since then, more Indigenous women across Canada have come forward with their stories, and according to Amnesty International, a lawsuit was filed in Saskatchewan that represents more than 60 Indigenous women who have reported being coercively sterilized in the last 10 to 15 years, the most recent being in 2014. In these cases, consent was obtained through coercive strategies such as intimidation, and in some cases the permanency of a tubal ligation wasn't adequately explained, which led patients to believe that this was a reversible procedure. If you would like more information about Canada's history of forced sterilizations or what is presently going on, or if you'd like more information about anything else I've discussed, please check out our show notes for resources.
Thanks, Taylor. I first heard about forced sterilization of Indigenous women in 2016 when it came out in a news article, and I was appalled that this was a practice that was still happening through coercion and subterfuge. The Canadian Senate's Human Rights Campaign just released a report calling for criminalization of forced and coerced sterilization. In 2022, this is just now being addressed. Not dealt with, no actual actions have been started, just a report outlining the fact that this is still happening and the recommendations needed to make it stop. And it's paramount that we actually act on those recommendations, and quickly. No person should have their bodily autonomy and right to self-determination removed like that. Before we begin the recording of the interview with registered nurse Anita Carroll, we're just going to take a short break. We'll be right back.
According to Action Canada for Sexual Health and Rights, only about 0.5% of safe abortions result in complications. These are generally minor and treatable, such as infection. Myths exist that claim that abortion can lead to breast cancer and other diseases, but these claims are not backed by scientific evidence.
Did you know, in British Columbia, you do not need a referral from a healthcare provider to access abortion services? You also do not need parental consent to have an abortion.
Did you know that even though there is no specific law banning when abortions can be performed, abortion providers can impose a gestational limit as a part of their practice depending on their training and the facilities available to them? This means that access to abortions beyond a certain point in pregnancy may be more or less difficult depending on where the person is located. Currently, no abortion provider is listed as offering the procedure past 23 weeks and 6 days in Canada. Welcome back to A Sound Constitution here on CHLY 101.7 FM. Up next, I sit down with Anita Carroll, a registered nurse from Nanaimo's Options for Sexual Health Clinic. We're going to talk about the important work they do in our community. Right now, so many people do not have access to a health professional for important sexual and reproductive health interventions such as STI testing, pap smears, gynecological exams, birth control, abortion support, adoption information. That's where Options for Sexual Health is such an important pillar in creating a healthy community. Anita is going to talk all about their services, who the clinic is for, hint, it's everybody, and important information you need to know for booking an appointment and accessing information from them. Thank you so much, Anita, for joining us today to talk about your work with Options for Sexual Health. To start, can you let our listeners know a bit about your work in sexual health nursing?
Well, thanks for asking me first off. My background in sexual health has always been through Planned Parenthood, which many years later transferred into Options for Sexual Health. So it's the same type of clinic doing anything sexual health for anybody anywhere on the spectrum of sexuality who needs help.
And you're also an instructor at VIU too.
That's correct. Yep. I've been teaching at VIU since 2003. So I've been there for a long time, and my background is public health nursing, and I've worked in many Indigenous communities on the Mid-Island, and that's where I got the opportunity to do some sexual health education and work when I was working with these different health centers.
So
Options for Sexual Health is a provincial-wide service. There are clinics all over the province. For those listening who may not have heard about Options, can you talk about what services are actually provided?
Yeah, so Options for Sexual Health is a clinic that helps anybody with their sexual health needs. So it could be a young one coming in to get birth control, to help them control their periods, or they're deciding to be sexually active and they want to be safe. It could be somebody who doesn't have a doctor and they need STI testing, or for a woman who needs a pap test and they don't have a doctor or has a doctor. It doesn't matter if you have a physician or not, that we're open for everybody. We are all across the province. And actually, the Nanaimo branch of Options for Sexual Health is one of the oldest, if not the oldest, in the province. And it's always been a very busy clinic. And yeah, we're very fortunate to have this clinic here in our community.
With Nanaimo's clinic having been present for such a long time, can you talk about the populations you serve? Do you find you have clients of all ages that utilize the services?
Yeah, we have people coming from mid-island to upper island. Again, we're finding that there's so many people who don't have physicians and they're needing these services. And some people don't feel comfortable just going into a walk-in clinic. Years ago when I started, 11 to 12-year-olds all the way up to 21-year-olds were our main population. Then now we're seeing an older demographics coming to the clinic.
It's interesting you mentioned the change in age. When we were talking prior to the recording, you had mentioned that you'd worked for Options for about 15 years, and then you left for 10 years to explore other endeavors, and you recently returned this last summer. What changes have you noticed since coming back?
So originally our clinic was at Prideaux Street. So it was easier access, I think, for some of the younger population. At that time, it was, 12 to 21, 22-year-olds was our main demographic. There was a lot of teaching about how to be healthy in sexual relationships, different types of birth control to use, doing a lot of counseling for people to make the right choice for their body, whatever was going on for them. And now I think with COVID, we've noticed a shift. Clinic had to shut down for a year because there was the building we're in was being demolished, and it's, we didn't have a place to go. We couldn't find a clinic space. And it took a while. It took us a year to find a new space. And now we're up on Dufferin Crescent, just beside the hospital. And we're seeing that the demographic is an older demographic that's coming in. So the youth that we used to see, we're not seeing as much. We're seeing probably, I'd say the median age is like 30 to up to 70-year-olds who are coming in. And a lot of people coming who have moved to the community and, been waiting 4 or 5 years and they still don't have a family physician and need to have some testing done.
But going back to that demographic change, do you feel it's related to the younger generation being online more and increasing information access through social media? Or do you think that there's more to it and why this shift has happened?
I think there's a multifaceted answer to that question. I think with us shutting our clinic down and not being available for that length of time, the younger generation had to find somewhere else to go because sexuality is always going to be happening. So I think they'd have to find other avenues for that. And for the younger generation, with health units in the schools, sometimes there are health clinics attached to schools. And through, Grant Avenue or Margaret Moss and Duncan, they do have youth clinics, right? But they only target a certain age group. And then some of the clinics on the island, they also will expand to 21-year-olds depending on the area, right? And that's the other piece is that they can give a reduced cost, the cost of birth control. We also do a much lower cost than what pharmacies are offering. So that's nice to be able to help people who have that as a concern. Due to COVID, we've lost some of the population. They've had to reinvent how they get services. And then, yes, again, transportation. How can we get to clinics? And we've had to change our clinics. We used to be open 5 days a week at various times of the day. And now our clinics are Monday to Wednesdays, 5 to 8. So when you think of some of those young ones who have after school jobs or working in restaurants, they might be working at the time that our clinic is. So we might have to reinvent that a little bit and change that up. So, and again, we have the older generation who are coming in. They have the same questions and concerns and health needs. So we're getting to them as well. But the other piece of this puzzle that's missing too is our sex trade population. We're not seeing them as much either. And again, is it a difference of where we're at? Not that there's one significant place in our community because sex trade work can happen anywhere, but being in the downtown core, it might have been easier for members of that population to come through there versus where we are right now by the hospital.
That really shows how integrated health is to service accessibility, while also recognizing it's not just our adolescents that need access to sexual and reproductive care and education. I wonder if people who hear about options think it's really only for school-aged people. Can you talk more about who is Options for?
Options for Sexual Health is for anybody who has any reproductive health needs. End of the story. You could be, a 15-year-old coming in to learn about things. You could be someone who's post-relationship breakup or divorce after 25 years and they're getting back into the dating scene and unsure about different things, or want to look at different avenues of type of birth control options or barrier methods to keep you safe when you're sexually active. To people up into, there could be older age that they're not sexually active but still want to have health needs taken care of, right? And we still have things going even if you're not sexually active. Our reproductive organs still give us issues at times that need to be checked out, and to be able to come in and talk to somebody and not worry. And that's one of the things that I've been noticing since I've returned this summer is the appreciation from members of the community who haven't had services. They're worried about getting services, and that they're coming in, and that we get to take that little bit extra time to talk with them and try to alleviate things and teach them different ways of what's going on is not necessarily a bad thing. It's just having that awareness of how your body is working.
That's some good points. With our current shortage of providers to address sexual and reproductive health concerns, I can see how important Options is to our community and making sure people have access to important services. Prior to our interview, when I was researching Options, I took the opportunity to explore your webpage, which is amazing and full of so much good information. For our listeners, that website is optionsforsexualhealth.org, but we'll also link it to our show notes. So the website has tons of great information, facts, lists of services, and a clinic finder, but I know that covers the whole province. Can you talk about what services the Nanaimo clinic offers, and is it just nurses that run this clinic?
Well, that's a good question. We used to be nurse-doctor run clinics, and at the Nanaimo clinic, we don't have any doctors associated with us. It's all nurses, and we are certified. We have certified practice for dispensing of birth control or whatever type of birth control that the person is looking for, as well as doing STI testing. So like I said, we'd have anybody coming in for what they need to help them be safe and not get pregnant when they're sexually active. And then taking through and teaching them how to use the different implements, for want of a better word, properly. We also do STI testing, so sexually transmitted infections. We do swab tests for women and urine specimens for men in the clinic. So if somebody has something going on that doesn't feel normal, or if this wasn't like this before, or there was an odor that wasn't there before, people get really embarrassed about these things, and they shouldn't be, because there could be a bacterial infection. And so we do testing for chlamydia, gonorrhea, bacteria vaginosis, trichomonas, yeast infections, and then we can also send people to local labs to have blood work for hepatitis A, B, and C, syphilis, and HIV testing. So it's kind of covering all of those bases there for the testing that we do. And then the other thing that we also do is we help women with their choices if they happen to be pregnant and they don't want to keep the pregnancy, or they want to continue with the pregnancy and give the child up for adoption. So there's those different options there. And we do help with counseling. And we used to, in previous years, we would sit and do a lot of counseling and do the referrals to other clinics. But what we do now is we give the client the information, and they directly reach out to those clinics, and they will help them and assist them with what they need.
I appreciate how Options works to not only provide services directly, but to help clients connect to other services as part of a continuity of care. It can feel like a lot of our health services is really piecemeal. So it's great to have this resource for people that no matter what their sexual or reproductive needs are, they're going to be able to at least make contact and have it looked into or taken care of.
Hey everyone, we're just going to pause the interview briefly just to take a short fact break. We'll be right back. Did you know one of the common myths spread about abortion is that women often regret their decision? However, a longitudinal study that took place in the United States from 2008 to 2010 found that over a 3-year period of check-ins, 95% of those who had an abortion did not regret their decision. Participants also reported that any feelings they had about their abortion decreased over time.
Did you know, according to the National Abortion Federation, 88% of abortions are obtained in the first trimester of pregnancy? Over half of all abortions are obtained within the first 8 weeks, with fewer than 2% occurring at 21 weeks or later.
Did you know that the efficacy of an oral contraceptive pill, also known as a birth control pill, is reduced when not used perfectly as directed? This includes not taking the pill at the same time each day or missing days. According to the Society of Obstetricians and Gynecologists, when looking at typical use failure rates, 90 out of 1,000 people will become pregnant within the first year of use.
If you are just tuning in, you are listening to A Sound Constitution here on CHLY 101.7 FM, where we are talking facts about abortion and gender-affirming care. Right now, we are sharing an interview I had with Anita Carroll, a registered nurse from Options for Sexual Health, discussing the important work her clinic does for our community. And now, back to the interview.
When it comes to education programs, I noted that Options website had many different programs listed. Can you talk more about that?
So I'll speak for our clinic in Nanaimo.
Sure.
So we're there, like I said, 3 nights a week. We used to do a lot of extra education many years ago, and working with intellectually challenged adults and youth, and do some of that work. But we have other people in our community, like Carrie Isham. Have to give a shout out to Carrie. She is so amazing, and she does a lot of that work now, and she is like a trailblazer. She used to be in all the schools in Nanaimo, and I know she goes to other school districts as well, and she does that type of work. So we used to do that many years ago, but we mainly right now focus on doing assessments, doing tests, and having those conversations with clients with what they need. And then out of the Vancouver office, they usually have a little bit more available there. And they have the Sex Sense line, which if people have issues and if they're attached to our clinic or to a Options clinic and they need to talk to a doctor, we do have a 1-800 number that I can give you. And there's doctors attached to that clinic Mondays to Fridays from 9 to 9 that they can say, hey, I'm a client at the Nanaimo clinic at Opt and I need to speak with the doctor. It's only for reproductive health issues. That's all we can do, but it's another option and ways to help.
So the Sex Sense line is on your webpage, but for our listeners, you can actually call the Sex Sense line if you are looking for information as well. It's a free, pro-choice, sex-positive, and confidential service made up of nurses, counselors, and sex educators. So that number is 1-800-739-7367. But we're also going to have that contact in our show notes on our YouTube when we post this episode. Now, we've talked about services, but how does someone access them? Do they need a referral? And to add to that, do adolescents who come need a parent or guardian with them to access the services?
Great question. Oh my God, that's a loaded one. So first off, if you want to come to the clinic in Nanaimo, you do not need a referral from anybody. You're welcome to phone our office number, which I can say it now and you can add to the end, but 250-753-9511 takes us to our clinic, which is Mondays to Wednesdays, and we're open 5 to 8. It's generally great to make an appointment. Sometimes if people don't show up, we can push people in if it's a drop-in. And we're located at Unit 8, 1599 Dufferin Crescent. So if you're looking at the back of NRGH, looking across the street where I think the Windward Pub is down below is where we will be found. And I think they did some COVID testing there, so that might help people know that little space. It's a small little area, but we have 2 clinic rooms and we have several nurses who run the clinics, and we're able to do any testing for STI testing, as well as dispensing whatever birth control people need. And it doesn't matter how old a youth is, that we encourage them to have that conversation with their parents. And sometimes we see parents coming in with their kiddos. We also, encourage, I'll just use this as an example, young women coming in with their boyfriends or their significant others, which I think is a beautiful thing to come together, to have testing done together, because that's healthy ways of being in relationship. But we're there to offer sexual health for whoever needs it, at whatever age group. And like I said earlier, we do have birth control that is a lower price than what you might get in some of the local pharmacies, as well as the morning after pill or emergency contraceptive pill. They go by both names. We have that available at a discounted rate as well, that people can come and purchase that as well.
Awesome. I love how you mentioned parents coming with their youth or partners coming in together. All are really aspects of healthy relationship building. And it's good that people realize that Options is always going to be a safe space to access services and education, and that there's minimal barriers to accessing these services. I'd like to shift course now to talk a bit about misinformation and disinformation regarding sexual and reproductive health. So, options for sexual health and your role as a nurse are important when it comes to providing factual information. And right now, we are seeing an increase in disinformation and discourse, particularly in political and social media spheres regarding topics like abortion, like gender affirming care, or vaccinations. Can you talk about your responsibilities as a nurse who works in this field when it comes to these topics that often have been used to create division and discourse?
Education. That's what it comes down to, is education. So what do? I have to keep myself up to date with all the shifts and changes in reproductive health. Even in my role as a professor, things are shifting and changing. That's the one great thing that's consistent in life, is change. So having to have information current and up to date. And of course, in our nursing professional body, and I know that as a student, you're learning this, and why we have you guys do all those practice appraisal forms, that's what we have to do when we're, official nurses and we have our credentials behind our name, is that we have to do updates every year. We need to stay current our practice, and things do shift and change. And, I think the one thing that COVID has taught us is that we can all go on different levels of things, and that teeter-totter of balancing and finding what's right for one person, which is different for another person. That's just part of life. So it's, I think, coming down to being respectful and being open and having good, honest conversations. And, I may have a viewpoint on something about sexual health, and you might have a total different viewpoint. It doesn't matter what yours is or mine is. At the end of the day, it's about being respectful and being able to listen. We don't have to agree. And I think that's the same thing about, abortion care or looking at vaccinations or that disinformation. We have to have these conversations. And the part that's hard for me is that for so many years, women have had this fight about their bodies. And at the end of the day, I will always support a woman and her choice. And this might be a little bit personal, but for me, and I'm going to share this because I think it's important when we're having this conversation. For me personally, as Anita, the woman, abortion does not work for me. It's against what I believe. But in my role as a nurse, my job is to sit with the client and say, what do you need? Okay, so let's get you the information to help you make the best informed choice that you can make for you and your body in this point in time. It doesn't matter what my point of view is. It doesn't matter what a doctor's point of view is. It's what that person that needs in that moment that we can help them with, right? So I say to student nurses all the time, we need to let go of our ego and what is going on for us when we go to the bedside or we go to the clinic in our nursing practice to give care to somebody. We go to where they're at, offer what they need, and try to keep them safe.
I absolutely agree about the role of nurses being there for our clients. We talk a lot about values and beliefs in our program and the importance of recognizing those, because we're going to have people we work with, whether it's coworkers or it's our patients, that are going to have different values and have different beliefs in us. We have this professional responsibility to provide safe, ethical, and evidence-based care. So it's really the recognition of a person's bodily autonomy and their right to access health services such as abortion, birth control, STI testing, sterilization, all without discrimination or barriers.
You know what? Years ago, there was a young lady who came, this is when we were at Prideaux Street, came in, and she was pregnant. And her family doctor said, I don't do anything about that. And he wouldn't refer her to anybody. And she, by luck, found us. But to me, what a miscarriage of our way of being as healthcare practitioners. You don't have to agree with it, but you still go to where the client is at. And it's, again, how do we put those egos aside to do the best for people, right? We know our own bodies. And we need to, as healthcare practitioners, listen to when our clients are saying, this is what's going on for me right now, and we need to do it, right? That was another little thing, is that we can make referrals too. If women have abnormal pap tests, we can also make referrals, especially if they don't have a physician that can make that referral. At Opt, we're able to do that for them as well. So,
as we wrap up, is there anything else you'd like our listeners to know about Options?
I think it's just a great organization that we get to do a lot to help people. And for me, it's about how do we destigmatize sexuality, because we still have people with a lot of different ways of thinking about sexuality. And just we have people who are asexual, but you still need to have your sexual health exams to make sure that your body's doing okay, because you still have all those bits and pieces inside of reproduction, all the way to the very far end with how people do things and feel and how they get their joy and their pleasure from sexual activity. So I think for people who have concerns or haven't had a checkup, or they have a new partner and they haven't been tested, come into the clinic and we can do that. It's pretty easy. We have a great team. We have a great person at the front desk, Cynthia, who's great at connecting people. And if you need to talk to the nurses, she links you through with us. So yeah, it's a great clinic. As I said earlier, we're open Mondays and Monday, Tuesday, Wednesdays from 5 p.m. to 8 p.m. And we can do a whole rapid type of testing to help people with their sexual health needs.
Perfect. Thank you so much for sitting down with me today to record this interview. It's really important that our community knows there are these resources available to them for their sexual health and reproductive needs, and that they can access this safe, confidential, and non-discriminatory service and education, because we really need that. Our people in our community do need that. So again, thank you so much, Anita. I really appreciate you.
No bother. Thanks for asking. And yeah, lovely to be able to support the nursing students and the good work that you're doing with Chile and getting all of this health teaching out there, because sometimes people don't hear these conversations on the regular radio station. So it's good that we have this opportunity for you guys to share this knowledge. So thank you.
That was Anita Carroll with Options for Sexual Health. I'd like to extend my deepest gratitude to Anita for taking time to chat with me. If you, our listeners, are in need of services such as STI testing, pregnancy testing, birth control, or have any questions or concerns related to your reproductive or sexual health, you can always check out their website at optionsforsexualhealth.org, or you can give them a call at 250-753-9511. We'll also have this contact info on our social media and YouTube pages for this episode. Next up, we're going to talk about gender-affirming care. There's a lot of misunderstanding of what this term means, who it applies to, and what it consists of, and the struggles that transgender non-binary people experience accessing services in Canada. Before Haben joins us, I want to share an audio clip from one of my favorite educators and social media accounts, Dr. Kinna McKinnon, a professor from York University who focuses their work around transgender health. The clip is an excerpt from a discussion they had about gender-affirming care in Canada as part of York University Research's YouTube page.
My broad program of research examines the social and structural dimensions impacting 2S LGBTQ people's access to healthcare. And we experience mental and physical health disparities, and it's necessary to be able to access care that's more tailored to fit our needs and meet with care providers who have been adequately educated to meet those needs. Gender-affirming care is not care that coerces trans and non-binary people to medically transition, which I think is a pretty commonly held misconception. And it's also not hormones and surgeries on demand that completely neglects clinician judgment. But what gender-affirming care is it's a psychosocial support and medical care that encourages health and social care providers to affirm people's gender identities and expressions. And beyond medical treatments for transition, like hormones and surgeries, gender-affirming care may also include better education of providers so that they feel more prepared to affirm trans and non-binary people's gender identities and expressions. In Canada, access to gender-affirming care is really fragmented. And if you live in Ontario, for example, the gender-affirming care services included in our provincial health insurance plan are very different from those provided in the Yukon, where the most comprehensive trans healthcare plan has just been recently introduced.
That was Dr. Kinna McKinnon, a professor from York University, talking about gender-affirming care. Now I'm going to pass it over to Haben to talk more about this subject.
Thanks, Dana. Today I'll be talking about trans-affirming care and access to healthcare. So first, I'm going to start off by defining these different terms. According to HealthLink BC, for transgender people, their gender identity does not match the sex that they were assigned at birth. Sometimes, gender identity is outside the two most common categories of male or female, and people who feel this way may use the term non-binary. Cisgender is when the individual's gender identity matches the sex that they were assigned at birth. Transitioning is about making changes so that you can live in your gender identity, like changing your name or getting gender-affirming medical care, but each person's journey is different and deeply personal. So let's talk about some of the available options. Living as your gender identity. This can include changing your clothing and using techniques like binding or tucking, changing your name, voice training, or other things. However, they feel the most comfortable expressing their gender identity. There are also medical options for transitioning, like hormone therapy. This is to help increase or decrease sex characteristics. For example, if you're in transition to male, the hormone testosterone helps develop male physical traits, such as hair growth on the face or body. Or if you're in transition to female, you may take estrogen to produce female physical traits, such as an increase in body fat and breast development. You can also get surgery or surgeries. These are procedures that change the look and function of your physical sex so that it matches the gender you identify with. To find out what's covered by MSP and what isn't, visit phsa.ca/transcarebc and search up surgery funding. Or check out our show notes, available on our social media pages for the exact link. Accurately identifying the size of the transgender population can be complex because of the very personal nature of gender identity and the fear of bias or discrimination on the basis of gender. People can experience discomfort and hesitation when asked their gender directly. In addition, research on the experiences of transgender people is still emerging as new data sources with information on both sex at birth and gender continue to become available. According to Statistics Canada, of the nearly 30.5 million people in Canada aged 15 and older living in a private household in May 2021, 100,815 were transgender or non-binary, accounting for 0.33% of the population in this age group, and that's about 1 in 300 people. And to strive for equality and equity of this minority group is especially important in BC, since British Columbia has one of the highest proportions of transgender and non-binary people aged 15 and older, at around 0.44%, according to Stats Canada 2021. Trans people often endure shocking violence and profound discrimination because of their identity. The following facts come from research conducted by Trans Pulse Canada in 2019 of 2,873 trans and non-binary people. In the past 5 years, 16% suffered physical violence, 26% had experienced sexual assault, 68% has been subject to verbal harassment, and 64% had avoided several public places in the past 5 years due to fears of harassment or being outed. And even though transgender individuals have the same right to access healthcare without being subject to discrimination, harassment, or violence, that's not what's been happening around in the real world. According to the same survey conducted by Trans Pulse Canada in 2019, around 12% had avoided going to the emergency room in the past year, despite needing care, and 45% reported having one or more unmet healthcare needs in the past year. So let's talk about some of the recent changes in Canada for transgender individuals. Starting in 2018, Statistics Canada began introducing the new question on gender and the modified question on sex at birth on most health and social surveys. Additionally, Canada is the first country to collect and publish data on gender diversity from a national census, which they started in 2021. The precision of at birth was added to the sex question on the census questionnaire, and a new question on gender was included. As a result, this addressed an important information gap on gender diversity. Now let's dive into some specifics about rights of transgender individuals. All of the following information that I'm going to talk about is from transrightsbc.ca. Transgender people in BC have the right to be given the same access to general public to services from a healthcare provider. In other words, they cannot be denied services from a healthcare provider on the basis that they are trans. If service is denied, a human rights complaint can be filed. If a medical procedure is exactly the same for trans people as it is for cisgender people, like hysterectomies, it is discriminatory for the healthcare provider to refuse to treat them on the basis that they are trans. Trans people have the exact same right to the same health plan coverage, which can be through the medical services plan or private health insurance, as cisgender people have for the same procedures. For example, if chest surgery was covered for men with gynecomastia, which is excess breast tissue in men, but not for trans men or non-binary people, this would be discrimination. Additionally, in a medical setting, discrimination could include a refusal to acknowledge a person's gender identity, chosen pronouns, or chosen name. For example, in 2015, the Vancouver Police Department was required to pay $15,000 in damages to Angela Dawson, in part for repeatedly being referred to by her birth name against her wishes. Now, those are just some of the general pointers. If you would like to find out more, please head on to transrightsbc.ca or our show notes for the exact link. Now, I'm going to quickly touch base on some of the procedures that may still be needed. This is based on the body parts that you have, whether that is ovaries, testes, prostate, breast, penis, or vagina. So first of all, pap smears to test for cervical cancer will be needed for anyone who has a uterus and a vagina. According to the University of California, San Francisco Transgender Care, because infertility is not absolute or universal in transgender people undergoing hormone therapy, all transgender people who have gonets and engage in sexual activity that could result in pregnancy should be aware of the need for contraception. And according to TransRight BC, transgender individuals have the same right to abortion as cisgender women. And at this time, there are no laws that prevent abortion in Canada. Prostate cancer exam for those with a prostate, and the general guidelines for HIV screening, prevention, and care do not differ for transgender people. Also, doing a self-genital exam for symptoms of STI, which can be passed during sex or intimate contact, is another healthy way for anyone. For more information about this, head on over to healthlinkbc.ca and search up genital self-examination.
Thank you, Haven, for breaking down some of the terminology and for helping our listeners understand that healthcare access free of discrimination and stigma is important for the well-being of transgender and non-binary people. As we wrap up this episode, I want to thank Anita Carroll for joining us from Options for Sexual Health. I want to also give a big thank you to my co-hosts, Cam, Taylor, and Haven, for sharing information and facts about abortions and gender-affirming care from a health perspective. I also want to thank our listeners for joining us through this episode. We hope it's helped to clear up some of the facts about these topics and the important reminder that they are just healthcare. In Canada, we need to make sure that everyone has access to reproductive and sexual health care. For details and show notes from today's episode, or to follow along on what's coming up this season, check out our Facebook page at A Sound Constitution. We also have Instagram at CHLY, A Sound Constitution, all one word, or Twitter at ASC_VIU. If you've missed parts of this episode, or you would like to listen to this episode or any of our other episodes from past shows, check out our YouTube channel at A Sound Constitution. Otherwise, we'll see you next week.